So now we move on to secondary assessment and reassessment. So the goal of our reassessment is to perform a systematic physical exam of the patient. And there's a couple of different ways we can do this. One is to complete a head-to-toe assessment, and the second is a focused assessment based on the complaints. And whichever one you do is going to depend on exactly what's wrong with the patient. In general, not always, but in general, you're going to want to do a head-to-toe assessment on all trauma patients. And with medical patients, you can usually do a focused assessment based on their complaints. However, this may not always be the case because, for example, with cardiac patients, they can have not only maybe chest pain, but they can have other things that have pain, such as radiation of the chest pain to their back or their arms or their jaw or something. They can also have edema of the legs and the arms, or they could have pulmonary edema in the lungs. So you may also end up doing a partial head-to-toe assessment on medical patients as well. So there's always been a question as to where is the secondary assessment completed at? And the answer is it depends. If your patient is stable, the secondary assessment can be completed on scene if that's what you want, or it can be completed during transport if the patient is unstable. Regardless of which way you do it, it needs to be a complete secondary assessment, and we're going to talk about that here in just a minute. So how and what to assess? In order to know what is abnormal, you've got to know what is normal. And one of the things that we do is we compare left and right as well. So we're going to compare left and right and top to bottom on many body systems. Here in a second, we're going to talk about body systems real quick. One of the things we will work on in class is not only showing you what is abnormal, but also showing you what normal is. Because that way, if you know what normal is, then when you see or hear or feel abnormal, you'll know it a lot quicker. So our secondary assessment is going to be carried out with several different kinds of assessments. We're going to inspect, which is done visually. So we're going to look at what the body looks like. So we're going to look for example, external bleeding, lacerations, fractures, deformities, those sorts of things. We're also going to use palpation, which is feeling or touching. And so we will learn to use our hands to inspect the body as well and palpate the body. And we use auscultation, which is listening. And for the EMT, most of the listening is done with lung sounds. So we will also, just as I mentioned, we need to know what normal is. We need to know what normal lung sounds sound like before we can learn what abnormal lung sounds sound like. So we will also in class, over the next few classes, be listening to lung sounds, both normal and abnormal. It is important as you do your inspection, palpation, and auscultation that if you have to expose the patient, and you will, make sure that there is privacy. We don't need spectators and unnecessary people around if we are exposing the patient. So now we're going to talk about the medical assessment. Depending on the complaint, as I mentioned earlier, can be a focused or full body assessment. So if your medical assessment is that, for example, they have abdominal pain, say they've been throwing up, they have abdominal pain, you may focus your assessment around the abdomen. But if they have, like I mentioned, cardiac pain, or if you suspect they're having a stroke, then you're going to need to expand your assessment to a full body assessment and find out, do they have, with suspected stroke, do they have weakness or paralysis on just one side of the body? Is it both sides of the body? Is it half, the bottom half of the body? That sort of thing. So, it may be, again, it's going to depend on exactly what the complaint is as to whether you do a focused or a full body assessment. The trauma assessment, which we will focus on more when we get to trauma, but we'll mention it here. Trauma patients need a full body assessment unless the injury is isolated. And so what do I mean by isolated injury? If you've got someone who is working at home and they hit their hand with a hammer, and that's all that's wrong, that's all they've done, then they probably don't need a full body assessment. They need an assessment of their hand and maybe arm, and that should be it. However, if you've got somebody that has fallen off the roof of their home, if they're up on the roof and they are putting roofing on their house and they hit themselves with a hammer and they fall off that roof and land on the ground, then you've got a different story. So you've got the injury to the hand, as I mentioned before, but then you've also got the fact that they fell maybe 10, 12, 15 feet. And so those people are going to need a full body assessment. So with trauma patients, when we're looking at full body assessments, there is a mnemonic that will help us remember things. And the mnemonic is DCAP BTLS. And the letters stand for D is deformities, C is contusions, A is abrasions, P is punctures or penetrations, B is burns, T is tenderness, L is lacerations, and S is swelling. So one of the things that's important with these mnemonics is that you don't just say the mnemonic and be done. The mnemonic is designed to help you remember what you need to think about checking. So if you are, if we're doing a scenario in class and you walk up and say DCAP BTLS, that's not adequate. What the evaluator should be asking you, or the instructor should be asking you, is what is DCAP BTLS? And you go through and you check each of those things. You check for deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling. If you're using the sample mnemonic, as we've mentioned earlier, you just don't walk up and say, what's your sample? You need to know. You need to go through and ask their signs and symptoms, ask their allergies, their medications, their past history, last oral intake, and events leading up to the incident. So these mnemonics are there to help you remember what you need to do, not to necessarily take a shortcut in stating what you're doing. So we're going to look now at body systems, and we will get more into this as we get into anatomy and physiology. But as we do a secondary assessment, and we're talking about full body assessment, we need to talk briefly about body systems. So there are 11 different body systems in the body. And during this section, we're only going to talk about a few of them, but I am going to list them here to show you what the body systems are. And then when we do anatomy and physiology a little bit later, we will get in depth and more detail with these body systems. So first is the circulatory system, and this is simply the blood and blood vessels and how blood is carried around the body. You have your digestive system, which is dealing with your food, oral intake, food and liquid intake, and how the body processes those nutrients. You have the endocrine system, which primarily deals with hormones. You have the integumentary system. This is the skin, and so we will look at the skin as part of this secondary assessment as well. It's very important, and I'll explain more of that here in just a little bit. You have the the immune system and the lymphatic system, which are sometimes grouped together. Depends on the type of medical program that you're in. We will likely group these together because they are somewhat related, but they also have their individualities as well. You have the muscular system, which deals with the muscles of the body. Then you have the nervous system, which deals with the brain, spinal cord, and nerves. The renal and urinary system, the reproductive system, the respiratory system, and the skeletal system, which is the bones. So those are the 11 body systems that we will eventually talk about in anatomy and physiology. We'll just talk about a couple of them here as we go through the secondary assessment. So one of the things that you need to review is how to perform a secondary assessment. This is laid out very well in the textbook, Skill Drill 9-2. So you should look at those pages and go through that extremely well so that you understand those each of those parts. But we will also go through that in class as well. So the respiratory system is what we're going to look at first. It's important to expose the chest with the respiratory system because it is not very feasible to try to listen to lung sounds with clothing, especially anything thicker than maybe like a t-shirt. But the ideal situation is to get directly on skin so that you can hear, you know exactly what you're hearing. So some things we want to look for with the respiratory system include signs of airway obstruction. So this is, does the person have an airway obstruction, or are they choking? Or is there something that is a partial obstruction? We want to look for symmetry of the chest. So are both sides of the chest doing the same thing? Are they both rising at the same time? Are they both rising with the same degree? So we want to look anytime we're looking at parts of the body that have symmetrical parts, for example, right and left, we always want to compare the two sides, right and left. We'll look at retractions and increased work of breathing. We're also going to measure our respiratory rate. So here's a chart that shows the ranges of respiratory rates by age. So at the, I'm going to start there at the bottom, and with adults, because that's most of what you'll see in our region. We don't have a lot of children that we see, but you do still need to understand what happens with respiratory rates as throughout the lifespan. So the adult is going to be 12 to 20 breaths per minute. The adolescent, which is 13 to 18 years old, is 12 to 16. School age, 6 to 12 years old, is going to be 18 to 30 breaths per minute. Preschoolers, 4 to 5 years old, is going to be 22 to 34 breaths per minute. Toddlers, 1 to 3-year-olds, are going to be 24 to 40 breaths per minute. And infants is going to be 30 to 60 breaths per minute. So naturally, these ranges are fairly wide, and this is going to a lot of the difference between is it at the bottom of the range or top of the range is going to be somewhat individual with patients, and also maybe what their condition is, what their medical problem or their traumatic situation might have been. Another thing we want to look at with the respiratory system is the rhythm. So is their breathing regular or irregular? And throughout the program, we'll talk about things that will make the respiratory rhythm irregular. There are, for example, brain injuries that can make it irregular. There are chest injuries that can make it irregular. So we will talk more about that as we get into those topics. We want to look at the quality. So is it silent or is it noisy? Normally, audibly with our ears, as most people breathe normally, you don't usually hear them breathe. So if you walk up to a patient and you can hear them breathing, or you hear noises coming from them as they breathe, what are those noises, and what's making those noises? And then we'll also listen to the lung sounds as well. We want to look at the depth. Do they have an adequate depth? So this plays into what we call minute volume. And minute volume is a mathematical calculation of respiratory rate times the tidal volume. So respiratory rate is how many times per minute that we're breathing. Tidal volume is how many milliliters of air that we are taking in with each breath. And so if you multiply the tidal volume times the respiratory rate, you come up with a minute volume. And an adequate minute volume is important for good homeostasis, to make sure that the body is staying in balance, that there's enough air exchange, oxygen, carbon dioxide exchange within the body. And then we're going to talk, we mentioned breath sounds. We're going to spend quite a bit of time on breath sounds in class and listening to different breath sounds. You'll notice with this picture that I've put here, the left side of the lung, the left lung has two lobes, and you see you have a superior lobe and an inferior lobe. The superior lobe is much larger than the inferior lobe. You see a little notch out of the middle of that lung, and that's where the heart lies. We want to remember that there is also, we look at pictures like this that are two-dimensional, and we want to remember that the body is three-dimensional. So we not only have a front, we have a back, and we also have a side to the body. So we will listen to all parts of the lung. And then the right lung has three lobes, which is the superior lobe, the middle lobe, and the inferior lobe. And again, we'll listen to all sides of the body for those breath sounds. This is a picture showing different places drawn on an actual human body to show you where those lobes typically lie. And everybody's a little bit individual, but this is, a good representation to give you a good idea. And then the small pictures in the middle just show places where you will listen with your stethoscope. And we'll talk about that more specifically in class. So we'll hit that, and I'll explain why those places and why not some other places. But one of the things that will be helpful to you is if you will learn generally where these lobes are at. So you can see that on the picture on the bottom left, it shows the upper, middle, and lower lobe of the right lung. And so you see that, right under the armpit is going to be the lower lobe. The middle lobe is going to be out more towards the front, about nipple line. And then again, right under the armpit, further down, is going to be the lower lobe. So learning these landmarks will be very helpful to you in developing your differential diagnosis. So as we continue on with the respiratory system, what are we listening for? So we're listening for several things. First of all, we'll talk about what are normal breath sounds. So we're listening for normal breath sounds. We're also looking for snoring breath sounds. And this is very similar to if you hear someone snoring when they're sleeping. It indicates an upper airway obstruction. It could be a foreign body. It could be the tongue. If someone is unconscious, their tongue will tend to fall down and block their airway. And so then when they breathe, it'll be just like at night when somebody is sleeping and they're snoring, that the individual who is unconscious may have snoring respirations. And there's other reasons for snoring respirations that we'll talk about as we move through the different portions of the class. So we're also looking for wheezing with breath sounds. And wheezing will indicate bronchoconstriction. And then we'll talk about, when we get into pharmacology, we'll talk about using bronchodilators as well. And then we're listening for crackles. Crackles is somewhat of it's a wet sound. If you think of, one example is if you take a little bit of your hair right next to your ear and rub it together with your fingers. That's one example of what crackles sounds like. Another is if you have a drink with a straw in a glass and you blow through it, then it makes bubbles, and that sound is similar to what crackles are. You have rhonchi. Let me back up just for a second. Crackles is fluid, so it can be caused from a variety of reasons, but it is fluid that is in the lung space, lung tissue. Then you look at rhonchi. You're listening for rhonchi. Rhonchi is usually a fluid, but it's very thick, and it will sound like if you blew through a straw through maybe molasses or something like that. It would be very thick, but you're still going to hear that bubble sound as you put air through that. And then we're going to listen for stridor as well, which is going to indicate upper airway obstructions.